So what exactly are you looking for on the OCT in terms of wet versus dry? What is your definition of that?
Well, dry to me means that we've made all the intraretinal cysts, the subretinal fluid, and the thickening go away as best I can determine on the OCT. So I don't tolerate intraretinal fluid, and I certainly don't tolerate subretinal fluid. Probably may overtreat some patients because of that, but if I think I've eliminated all the fluid, I'll go to an extend mode.
And the reason I ask is, would you classify sub-RPE fluid within that dry versus wet classification scheme?
Well, in the beginning, I try to dry everybody out, and sometimes, after a number of injections, the RP detachments may eventually, the sub-RP fluid may go away, but after 3 or 4 injections, and I do bring them back again to check to see if I'm getting any response and it's just not working, then I would probably assume that that's going to be I'll go into a maintenance phase basically, and that I may not be able to collapse that. I may determine, at some point, recently I've been switching some of those patients to aflibercept or Eylea because it seems like they close the RP detachments a little better.
And it's different persistent versus new. New sub-RPE fluid, defined as darkness below the RP level that wasn't there on the last scan, is always disease activity. There are people with large serous PEDs that may or may not be related to wet macular degeneration. It could just be a manifestation of their dry pump.
And I would also say that I think the longer, at least in my experience, we're treating, wet AMD, I'm finding that really there's really no set guideline that you can apply to a majority of patients. Each individual, there's so much variation in each patient that comes in and how you follow them and how they respond to the anti-VEGF and what is persistent, a little bit of persistent subretinal fluid perhaps, which stays there despite re-injection and re-injection. You may tolerate more than perhaps, like David was saying, intraretinal fluid, which in the CAT study was shown to be associated with more severe vision loss. So all these variations, I'm finding, makes the decision really individualized more and more, so that each patient has their own kind of little moniker that I apply to them. And as they come back, I really kind of try to individualize the therapy for that patient, because really I'm finding across the board there's just so much variation in how patients respond that you can't just say one size fits all. I think it's really an individual approach.
Well, and also I think that you have to look at the status of the other eye, and you have to look at the patient overall. Some patients cannot come in every month. I mean, it's impossible for them. They don't have the caretakers to bring them in. I think you have to look if that other eye has been lost by a hemorrhage. I probably would just continue monthly treatments on that one-eyed patient. So I think that you have to look at the other eye and the status before you can make a decision of how you're going to treat them.
Yeah, fluid's interesting. We know from the CAT studies, we know from the VIEW studies, that these patients aren't drying up. The majority of patients still have some degree of fluid. It may be minimal, a few intraretinal cysts, it may be more, but I think gauging it to the individual patient. If I have a patient and I've treated them and their volume scan is essentially unchanged over several visits, there's a small amount of subretinal fluid, and I haven't gone into a drug switching protocol, which we'll talk about later, to try to dry them up, I may be comfortable with that patient at that level. Another patient who has a PED and we treat them and it gets a little bit smaller, and treat them again and it gets a little bit smaller, those are the rare cases of PEDs where I'll continue to treat to get an effect. But if I treat them and the fluid goes away and the PED is stable, I don't go after that.
Do you use any other imaging besides OCT at your follow-up visits? Routine follow-up visits, we'll talk about sort of, quote, non-responders in a little bit.
I don't.
So does anybody else get like routine fluoresceins or?
But I do think it's important, as David said, to compare those to previous scans. Sure. And to look at the full volume scan on them as well.
Well, there's also, how the patient is doing and also where they are year to year. So it's not uncommon if I see somebody who's kind of not doing as well as I would like them to do. I mean, they might have still a little bit of persistent fluid that can't dry up. At a yearly basis, I might just do another fluorescein to see what's happening to their neovascularization. When we looked at data in both Anchor and Harbor, we found that patients, even though they were on monthly Lucentis, for example, there was a small subgroup of patients in whom their neovascularization grew, but their visions remained stable or improved. So there's still a lot of variation that's occurring in these patients in terms of their neovascularization, and that may prompt me to change my management. So I don't do it routinely, but again, I individualize it for the patient, and maybe on a yearly basis, we kind of reevaluate where they're going.
You know, we're probably underutilizing fluorescein angiography, and there's two places where I think that that's shown. One, if you look at the CAT and the Harbor PRN data, the lesions are growing with PRN therapy. And so if you don't do a fluorescein, you don't know that. And I call PRN progressive retinal neglect, because I think you're basically letting the retina get over and over edema. It may be, though, that even though we think we're doing the right thing with treat and extend, we may be doing treat and extinguish. You know, if we allow lesions to leak at all, they may be growing over time. You alluded to the fact, or Carl alluded to the fact that you can have a dry OCT and still have leakage on fluorescein. The RPE pump's pretty good, so sometimes it can pump out leakage. And so I also think it's important to do the fluorescein if you're really thinking about extending out to a period longer than you think the drug may be acting, 8-10 weeks. Probably they need fluorescein before you go longer than that.
So Dave, you would get a fluorescein there, and what if you don't see leakage there? Then you'd extend. But if you see any degree of leakage, see,
Tighten up.
my problem is I find fluoresceins very difficult to read after anti-VEGF therapy.
Oh, they are.
I think it's very difficult to tell whether there's leakage or staining. And so the OCTs have become an invaluable tool.